All right, so this next section, we're going to be talking about diverticulosis and diverticulitis, which are kind of two different versions of the same type of problem. So the pathophys behind these types of problems is that we've got small herniations of the bowel through the smooth muscle. So the lining of the bowel kind of herniates inward towards the towards the internal surface through the smooth muscle of the body, and that's kind of where we get it. So the diverticulosis is the presence of these herniations. It's these little pockets that invade into the smooth muscle. Diverticulitis, because it's an itis, this is when these herniations or pockets become inflamed. Here's what that looks like. You can see all the little diverticulosis pockets kind of all over the place in that bowel. They protrude from the mucosal lining into the smooth muscle. The reason people get these low fiber diets can be a source of exacerbation of these types of problems. The decrease in bulk makes constipation worse. Anytime we're having like dilated bowel, we can develop these kind of outcroppings or pockets into the smooth muscle. The increased pressure from constipation, from large volume fecal matter moving through the bowel, is what can kind of make people susceptible to developing these. Diverticulitis, the inflammation component of this tends to happen when food material or digestive material gets trapped in these pockets, and over a period of time, that kind of stagnated material causes inflammation around the mucosa in that diverticular spot. The problem with that is that because there's a lot of inflammation over a long period of time, it can lead to bleeding. So patients can have blood-streaked stool as a result of diverticulosis or advanced diverticulitis. For our assessment stuff, diverticulosis is asymptomatic. These little outcroppings that people develop into the smooth muscle that don't fully perforate the bowel don't usually cause symptoms for patients. If they do, there's going to be things like bloating, flatulence, kind of really non-specific symptoms that people experience. For diverticulitis, patients are symptomatic. Because we have an inflammatory response going on, there are going to be symptoms associated with that. So things like abdominal pain, fever, or leukocytosis, which we see in their labs, so an elevated white blood cell count, and also palpable masses on their abdomen. So these are going to be like little tiny masses, kind of nodules that you can palpate around where their colon is or where these diverticulitis kind of areas are on the body. For our medical diagnosis, it's a lot of screening, a lot of interview, because we're looking for the presence of this diverticulitis. Diverticulosis, we're not necessarily looking for because it's not going to produce a lot of symptoms. So presence of symptoms or not, kind of what is their regular bowel activity, what is their diet like, do they have a history of constipation, is another big question that we ask patients when we're trying to figure out these things. CT scans can visualize diverticulosis pockets if we're looking for them. Usually we're going to have to use contrast with that CT scan so that we can visualize the dye kind of getting into those pockets within the bowel. For diagnostic, our real diagnostic thing is colonoscopy. So it's our endoscopy procedures because we want to visualize the pockets. So here we can see a bunch of diverticulosis in a patient's colon, all these little kind of caverns out to the side. And here we've got a pocket of diverticulitis. We can see that there's some infective material, kind of some inflammatory exudates that are stuck in that pocket. So that's going to be our diverticulitis. As far as we're concerned and how we're going to manage these things, the things that we're looking for, we're dealing with a lot of risk for problems for these patients. So risk for infection as a result of material being stuck in those diverticulitis kind of outcroppings. Risk for ineffective thermoregulation, talking about fevers and that type of presentation. Risk for constipation, since we know that that's a risk factor for developing the disease. Patients continue to be at risk for that throughout. And ultimately a risk for bleeding if we have severe diverticulitis that actually ruptures the small intestine, the colon, from long-term inflammation. So our medical plan, things we can predict that the doctors are going to want to do: colon, rest. If we've got diverticulitis, they want to rest the colon in order to allow that inflammation to go down naturally. So we're going to be putting these patients on NPO status long term. They may be NPO for several days, up to a week, long enough that we may need to talk about doing an NG tube, maybe IV fluids, and possibly moving into some enteral or parenteral, more likely nutrition, to supplement what they're not able to take in orally. We're going to slowly reintroduce foods once symptoms has resolved. So we're going to start with clear liquid diets and then very slowly baby step our way back up to regular diets. So the progression will go clear liquids, full liquids, soft, bland, then back up to regular. So there's going to be several steps. It's not going to be one of those like PO challenge kind of things where it's like, great, you can drink something, let's go to a regular diet, get you back up to normal. It's going to be a much more slow and intentional advancement of that diet. For surgical management, we really only consider this when there's really advanced complications of that those diverticulosis or itis pockets are causing. Things like hemorrhage, so we've fully perforated the bowel, obstruction, abscess formation, or perforation, which kind of goes along with hemorrhaging. So abscess formation, if that inflammatory pocket, that food material that's causing the diverticulitis kind of closes off, it can form an abscess pocket, and that would require more of a surgical management to wash out and remove that area of abscess. Colon resection is for very advanced cases, kind of like those ones we saw in the picture earlier. So like these guys where there's really a significant volume of diverticulosis outcroppings in the colon. There may need to be a partial or total colon resection depending on how the surgeon or the gastroenterologist feels that absorption and risk of complication is really going to go moving forward. These patients may also end up with a colostomy as a result of that need to remove part of the colon and promote colon rest so that those diverticulitis pockets can heal. So these are going to be things like our double barrel, which is our most temporary version of a colostomy. One of the big risks here associated with diverticulosis and itis, that inflammation, is a bowel obstruction. So this can be both an exacerbating factor for patients producing diverticulosis pockets and also a result of having those pockets. Both of them are not promoting smooth movement via peristalsis through the bowel, so there's a very high risk. We do change the names a little bit based on where the obstruction is in the body. So if it's in the small intestine, it's a small bowel obstruction. If it's just a bowel obstruction, it's in the colon, so a large intestine problem. With bowel obstructions, there's a couple different reasons that patients can develop those, either mechanical or paralytic. Mechanical meaning a blockage, right? So these are going to be problems really secondary to our diverticulosis and diverticulitis presentations. Paralytic ileus is a neurologic issue. It's where there's a segment of bowel that is neurologically paralyzed so that peristalsis doesn't happen. So as soon as stool material gets to that section that's paralyzed, it can't move forward. And as more and more fecal matter kind of goes through that paralyzed section, it impacts or becomes very hard and obstructs the rest of the bowel. Here's where it gets gross. Patients with a small bowel obstruction, so their small intestine, if they have a paralytic ileus or a blockage and develop a full small bowel obstruction, they're going to continue to produce stool content just from regular cell lining, kind of degradation and replacement, and also from continued ingestion of food material. But it's not going to be able to continue traveling through the GI tract. So patients are going to start vomiting and losing electrolytes through their vomit. But the contents that they're going to be vomiting, it's stool. It's partially digested, digested isn't really the right word, but partially formed stool. So it gets pretty gnarly. These patients who have this syndrome where they have a small bowel obstruction, they're vomiting, we're going to be putting an NG tube in those patients and doing what's called gastric decompression, meaning we're going to hook that NG tube up to wall suctioning and suck out all the fecal content so that we're decompressing their abdomen. Sometimes that's enough to help the small bowel obstruction move on and start passing through the rest of the GI tract. Sometimes it's not. And if not, then it's going to require a surgical intervention. But that is our closest kind of serious problem associated with diverticulosis and diverticulitis that we want to look out for, is those bowel obstructions that patients can develop. So our nursing plan, GI assessments. We're going to plan to do a lot of GI assessments on our patients, looking for things like acute pain, decreased activity, like bowel activity, because we don't want to see any of these obstructions or partial obstructions start to really dilate the colon, which can lead to further development of diverticulosis pockets in the colon. Also, nutritional support. Low fiber diets tend to be more associated with the development of diverticulosis. So we want to teach patients about high fiber diets and how they can supplement fiber in order to prevent the further development of diverticulosis. And also increase fluids, lube the tube. Best way to prevent getting obstructed is keep the tube lubed. So here's kind of what that would look like if it was a really kind of gnarly looking thing. Here's our colon, here's our little diverticulosis, here's some diverticulitis pockets. And the problem here is really that if we get diverticulitis, it can form fistulas or kind of new openings between two different places that shouldn't be connected, like bowel and bladder or bowel to skin outside the surface. It's kind of an abscess tunnel where that infected material has traveled through the body. So we can start to see invasion into surrounding tissues if diverticulitis isn't treated and kind of left to its own disease advancement. So for implementation, NG tube management is a big thing. So we're going to need to verify that it's placed routinely. It's one of the common tasks that we have to do just to make sure that device is safe for use in our patient, even after insertion. So the way we do that is we need to verify 2 of 3 different ways. For initial placement of an NG tube, we always need to get an X-ray so that we can visualize that the tip is in the stomach, where it's supposed to be. After it's placed, we need to verify it every shift or every time we're going to use it. And some of the ways we can do that is we can inject air. We use like a 60 cc syringe, hook that up to the NG tube, and we can inject some air and listen with our stethoscope over the stomach. And while we're injecting air, we should hear gurgling in the stomach. That's indicating that when we're injecting things, it's going to the stomach, not to the lungs or somewhere else. Then the next thing we want to do is actually aspirate stomach contents out of that same syringe. So we can inject air, listen for gurgling, and then pull out stomach contents. So we should see digested liquid material coming out of there. Those are 2 ways that we can verify placement. We can also aspirate stomach contents and then use pH paper to put a small sample of those stomach contents on the pH paper. And the test should indicate a very high acidity level because of the stomach acid. So those are a few ways that we can verify placement of an NG tube. Also, NPO status, we're gonna have to maintain that for our patients. Anybody who's got an NG tube kind of should be NPO because anything we put in their mouth is gonna go to their stomach and the NG tube is just gonna suck it right back out. So they kind of are NPO by default. This doesn't mean that patients don't get thirsty or require oral care when they have an NG tube. So for patients who get thirsty while they're NPO, one of the things that we can use is those little like sponge swab things on a stick, and we can moisten the oral membranes, the lips, the mouth, the tongue, those areas, in order to make sure that we're addressing kind of that dry mouth feeling associated with not being able to drink fluids. So we do still want to pay attention to thirst and oral care for patients even when they're NPO status or have an NG tube in place. Diet support is a big one. We want to facilitate patients getting a high fiber diet while they're in the hospital and make sure they're set up to continue with a high fiber diet as an outpatient after their hospitalization. And then ostomy teaching. Again, this is going to be a short-term thing, but they're going to need to take care of that ostomy by themselves, meaning that they need to be ready to perform self-care of the ostomy independently for a period of weeks or months before it can be re-anastomosed, sewn back together, and kind of the bowel corrected to its natural diversion, not through an ostomy on the skin surface. So we do need to plan for doing teaching around how patients should be performing ostomy care independently. So for evaluation, it's the readiness for self-care is the big one. High fiber diets and ostomy care are two big categories. We need to make sure that in the short term, these patients are going to be able to manage this disease process independently while they're outside of a care environment so that they can have the reversal of that ostomy or alleviation of symptoms as quickly as possible and for as long as possible. So those are really our big areas of focus when we talk about diverticulitis and diverticulosis.